Welcome to the Pharmacists Are In, a podcast made for pharmacists by pharmacists, hosted by John Papasturjo. John is a frontline community pharmacist owner, assistant professor at the School of Pharmacy at both the University of Toronto and University of Waterloo, and an internationally recognized speaker, author, and researcher. Today's guest is Hazem Elewa, a clinical assistant professor at the Qatar University. Hazem runs an anticoagulation clinic in the hospital setting in Qatar, building on his experience as a postdoctoral fellow studying pharmacogenetic guided dosing of warfarin at the University of Florida. Join John and Hazem as they discuss the current state of both community and clinical pharmacy practice and the campaign for a greater scope of practice in Qatar. They will keep you up to date on the current pharmacogenetic research being done on warfarin dosing, how pharmacogenetic clinics are implemented in Qatar, and the future of pharmacist-run pharmacogenetic testing. Pull up a seat and let's get started.
And we're here again at the 78th World Congress of Pharmacy and Pharmaceutical Sciences. Great opportunity to meet internationally renowned pharmacists, and I'm here today with Hazem Elewa from Qatar. Hazem, welcome.
Thank you, John. Welcome. Glad to be here at FIP.
Yeah, FIP is always a great opportunity to kind of go out and about. I find there's a ton of value in the networking. You get to meet cool pharmacists doing interesting things. Generally, pharmacies, like in your home country, is almost like a bubble. You know everyone, and then you get out to FIP, and literally there's a whole world out there of people doing great things. Sometimes it overlaps with what we're doing in our home countries. Otherwise, it doesn't. But the learning opportunities are endless. I mean, Qatar is a place that I don't know anything about with respect to pharmacy practice. Tell me a little bit about that.
Yeah, so Qatar is kind of a small country. We population is about 2.5 million. About 500,000 of them are Qatari nationals, and almost 2 million of expats from all over the world. Wow. So it's more of an international community, if you will. And the practice there, it's a growing country, so there is a lot going on in the health sector as well as education research sector. So definitely there is a lot going on over there.
And we didn't really even talk about what you do as a pharmacist. Community, hospital, what's your practice like?
I'm currently a clinical assistant professor. I work primarily at Qatar University College of Pharmacy. I also am cross-appointed at one of the hospitals in Qatar. It's called Al Wakra Hospital. And I go there about 2 days per week to run their anticoagulation clinic, as well as mentoring, supervising PharmD students and residents sometimes.
That's awesome. So when I think pharmacy practice, I have this vision in Canada of the community pharmacists. In Qatar, is it similar or is it different? What would you say?
I would say the practice is maybe a little bit different than Canada and the States in the sense that there's a main big umbrella of an institution called Hamad Medical Corporation. And basically under that big umbrella, there are like about 7 hospitals. And then underneath these 7 hospitals, which are primarily given like the secondary and tertiary care, but there are like a bunch of different primary healthcare centers. And everybody who is a resident in Qatar, they do have coverage for health insurance. Okay. So basically, if they have any routine need, they would go to the designated primary healthcare center. Otherwise, they can go to the emergency department of any of these hospitals, depending on their need. So some of them are specialty hospitals. Like, for example, we have the heart hospital. We have a cancer hospital called NCCCR. And then some of them are general hospitals. Yes, it's a little bit different.
So you get a script from the prescriber. Do you take it into a community pharmacy? Is that how it works?
Most of the time, if you get it in the hospital, you would get it dispensed from the outpatient pharmacy of that hospital. If you get it from the primary healthcare center, you would dispense it in also the outpatient pharmacy in that healthcare center. Sometimes you could interchange where you can get it. Sometimes you are discharged from a hospital, but you can get it in your designated primary healthcare center for the convenience. But most of the times, people don't get it dispensed in private pharmacies or community pharmacies unless they get that prescription in more of a private polyclinic or a physician office, if you will.
Okay. And the pharmacist's role, are they there primarily in the community to dispense, or are they providing health information, doing a therapeutic check? Like, I'm trying to get a sense for the scope itself.
Again, it can be very advanced when you go to the hospital, and you do see a lot of clinical pharmacists and a big role in therapeutic interventions. Kind of rotating on the different floors and intervening really proactively in a patient-centered sort of a healthcare system. Again, also we do have a bunch of different collaborative care kind of practice in primary healthcare centers as well as in some of these hospitals. When it comes to community pharmacies, this is where there is a little bit of a gap in the practice, and you do see a need for advancement a little bit. It's coming up, but again, it's not to the same level where you may see in other countries like in Canada or United States, where there's a lot of therapeutic intervention. It's primarily dispensing.
Yeah. So I mean, this is one of the things I've kind of learned. In some countries, there seems to be this shift between the hospital pharmacists and the community pharmacists. And I was joking with someone here. They said, "Well, I'm a clinical pharmacist," and I said, "Well, isn't every pharmacist a clinical pharmacist?" But not necessarily. In some parts of the world, there is that. And I know you guys are doing, making a big push to try to elevate that community pharmacist. And I see that trend in different parts, of the world. And I think it's a great thing because, those community pharmacists are the ones that are seeing most of the patients, right? Yeah. How about things like, would you see like vaccines or immunization be given in a community pharmacy?
Still, this is one of the fights that we're actually going through, trying to convince, the authorities and the different stakeholders that pharmacists can do this and can be, providers of immunization, other sort of care. But it still didn't happen yet because maybe there's not that much trust in the community pharmacies and community pharmacists. But again, we do see a lot of advancement happening in the hospital. For example, collaborative care, anticoagulation clinics managed by pharmacists. This is something that have happened in maybe about 6 years ago, and it started with one hospital, and now we have 3 hospitals that have pharmacist-managed anticoagulation clinic.
And that's how it starts. I think, it may be the hospital pharmacists that push the scope, forward and forward, but eventually it trickles out to the community as well. And it, also starts with the students. I had an opportunity to give a lecture, I think, via web link to one of your classes. And just by the types of questions, we were talking about innovative practice in Canada and whatnot, you could tell there's that appetite, right? And I think that's consistent. Pharmacy students all over the world, they have this appetite to do more because they're being trained differently, right?
Very true.
And they're not waiting. Their ultimate goal is not to fill scripts. It's to be, a clinical practitioner. So I mean, stuff like this helps, man. These big conferences, you get everyone out, see what everyone's doing, and I think ultimately everyone's going to get there. It's just going to take different times. I know, one of the things that kind of brought us together is your interest in pharmacogenomics. I know that's close to my, near and dear to me, and I do a lot of work in this area, and so do you, and real value in being able to meet people like you, because you've really kind of led in this area also.
Yes, I think it all started with my postdoctoral fellowship, which was a fellowship in pharmacogenomics at the University of Florida in the United States. And my main project was actually being one of the investigators on the COAG study, which was a multi-site NIH-funded study looking at the effect of genetics in pharmacogenetic guided dosing of warfarin. And truthfully, it was a unique experience, being one of the investigators and being a research coordinator on that site. You get to see a lot into the clinical practice as well as how this integrate into the research area as well. So you're responsible for screening possible patients that are eligible for that study, as well recruiting them, do all the follow-up visits. So it brought me into the picture. I stayed there for about 1 year, and then started also going into clinical practice in the United States in Georgia as anticoagulation clinical specialist pharmacist. And again, we brought Georgia as another site for that study. Mm-hmm. So I remained with that study for about 3 years. And indeed, when I moved to Qatar as assistant professor, I tried to again build on what I've already learned and my experience in pharmacogenetics and start to do a pharmacogenetic study in Qatari patients. As you all know, that it may differ from one population to the other, and this is one of the main things that is pharmacogenetics unique about, is that it could be really different from one population to the other.
The evidence is slowly starting to mount. We don't have a ton. I mean, we published kind of one of the first papers out of community pharmacy looking at, a broad range of therapeutic areas. I know you're collaborating on a project with myself and some of the other IPAC members here on on looking at the genotype of patients on warfarin that are poorly controlled. So hopefully we'll find some correlation there as well. But I mean, we're getting bits and pieces of this evidence. The reality is, and I don't know how you feel about this, if pharmacists don't take this role on, someone else is going to take it from us. It's getting a lot of media attention. I mean, it's out there now. What do you feel about that?
Totally agree, cannot agree more. And it was one of the very first things that I did when I moved to Qatar is try to, get in one of my undergrad students' projects is to have a survey into the different clinicians, primarily physicians and pharmacists, and try to get the sense of how they feel about like their knowledge about pharmacogenetics as well as their attitude of what should be the role of pharmacogenetics, who should be, like the type of practitioner who should get involved more. And surprisingly, physicians and pharmacists both agree that pharmacists are the best people or like the best kind of practitioners that are equipped with the tools to get them more and more involved into that. And it's a whole area that we can intervene and we can get involved in right away.
Yeah, and you touched on this relationship with the physicians, because early on I remember starting to talk about it. The physicians, they think it's interesting. They don't have a ton of training in this area either, so they're happy to let us champion it. My concern is if pharmacists adopt it too slowly, we're going to give it up, and I really believe there's going to start being some reimbursement in this area, because as the evidence comes out, hey, are we helping with outcomes? I think so, and possibly the evidence will show that. Are we saving dollars? I think we will as well, right? So
yes, and I think also right now the practice has been changing in some countries like Canada and the United States, where they do have currently pharmacogenetic clinical services, and they are run by pharmacists. It's like on consultation basis. They would get reimbursed by insurance companies. So definitely it is a great opportunity, and we are well equipped because we are the expert in pharmacodynamics, pharmacokinetics, which is all about pharmacogenetics.
Yeah, and we're running a randomized trial now. I'm the lead investigator on it. We're actually blinded, first time I've ever done this, but it's funded by a third-party payer, an insurance company. They've stated, at arm's length of the study, but the reason they funded it is they want to see, hey, if we could show a positive outcome, these patients improve, we get them off disability claims, they're going to save money, eh? So I think this will be important. If we're able to, get a positive outcome, I really believe we're going to start to see reimbursement in this space almost immediately. But we got to show the evidence. And historically, pharmacists haven't been good, especially community pharmacists, at documenting what they're doing, showing the value. We all know anecdotally we do great work. We work in a little bubble. But I mean, the call to get evidence across, pretty much everything we do, I think is very, very important.
I also agree on that one. And I think here's the place where you have to collaborate more with different pharmacists, different clinicians, physicians, nurses, and trying to get the research and the translation type of research where you can prove really that this can improve the outcome or not. So one of also the studies similar to yours, where we are looking currently at a SANE TTR score. This is a score that is used or has been implemented by some in order to find out who are the patients that could possibly be poorly controlled on warfarin, and try preemptively put them on a direct oral anticoagulants instead of putting them on warfarin. So one of our studies that we're currently doing with our students is to look at adding into that the pharmacogenetic component, so see if this could implement the same TTR score. So I think all these kind of pieces and bits, when you add them together, if we show that they can improve the outcome, eventually pharmacogenetics will be one of the most important things that we could do.
I wanted to ask you about the test itself, because this is, I think, we were starting to see companies pop up everywhere. One test is $500, another test is $99. Talk a little bit about the differences, why it's important to use a robust technology. I think the run-of-the-mill pharmacist that's thinking and dabbling in this area, they have to have an understanding before they just jump in.
Again, this is one of the places where you do need to have a lot of knowledge about, is that the different types of testing, whether it has been done in a CLIA certified,
Sure.
for example, lab, or whether this is just for research purpose. Again, there is a lot of robustness when you use, for example, CLIA certified labs, because their techniques have been already validated and has been shown to have high sensitivity and high specificity, which is a really important component, because you don't want to give false results, for example, to your patient and base your evidence or recommendation on that. So again, like I understand there are like a lot of different companies, but again, you need to learn more about the different methodologies used behind these testing, whether they have been certified, not certified.
And one of the other things too, especially when you're thinking a broad therapeutic area, and I mean, for this to be applicable, especially in the community, you're not only going to worry about, warfarin, it's going to, it go across a lot of different disease states. And I mean, that's how we do it in practice in my genetics clinic and my community pharmacy. But one of the other things is just the number of genes that the test is evaluating, and then the number of alleles as well. In Toronto, we're in a really multi-ethnic, diverse kind of population of patients. If you're looking at a really narrow kind of spectrum, you're going to miss patients for sure. I mean, it may not be as big of a deal if you're in a really homogeneous population, but I imagine Qatar with all these expatriates, the same thing. You're seeing a lot of different people, right?
Exactly the same. Yes, if you look at Qataris, they may have certain mutations or SNPs, single nucleotide polymorphisms, that are unique to them or to Arab populations. But again, we do have about 2 million of expats coming from Asia, coming from Europe, Canada, United States, Australia. So again, you need to focus more on the very most common alleles and mutations so that you can catch the majority of the patients.
And then, so anyone, if any of our pharmacists are listening now and they want to do this, the first thing you do is reach out to someone that's done it and say, hey, I'm thinking of using this test over that test. What do you think? Get some opinions, because I think this is another area that's gonna explode. And I think if we're gonna champion it, we got to make really good decisions with respect to the vendors we partner with, right?
Yes, because you want it to be cost effective, and in order to do that, you want to make sure you use the right test. You don't want to use a test that test for a certain allele that is very rare, and you will probably not catch it except in 1 in 1,000
That's
or
right.
100,000.
Do you see a time, and relatively soon, where everyone's going to get one of these tests before we do anything?
We hope so. And again, this is one of our dreams to start to see this clinically implemented. From my clinical practice, from my research expertise, I've been seeing this happening more and more. And the advancement, of course, as well as even the pricing of the clinical, of the pharmacogenetic testing is getting lower and lower. So this all going to add to that picture where eventually we're going to see this as one of the routine labs that are done.
The geneticists are telling me, this technology is evolving so quickly that in 5 years it's going to be pennies to do the actual testing. So the value will be in the consultation, right? Patients, they get these reports, and I've seen it. They get the reports, they come and they panic, they see all the different drugs listed. They're not even on 99% of the drugs, and they get worried when they see red, yellow. It really is about, is the pharmacist able to sit with that patient, explain the results, and really make good clinical decisions? And it's not going to happen in a bubble. You're going to have to collaborate with the physicians and everyone else. But what I'm finding from the physicians is they're buying in. It's taking some time, but we send back recommendations. First time, maybe we reach out to a doctor, like, what is this? Where did you get this stuff from? But once they understand that, they're like, we're now empowered with something more than just our a blanket recommendation. We've got a result here that's given us some weight, I think, and that's important.
It is very important indeed, and I think this is a very good opportunity for pharmacists to get more and more trained on it. There's a lot of ongoing continuing education programs on pharmacogenetics and the clinical implementation of pharmacogenetics, and definitely this is the time to start to get more active into the area.
We've had a chance to collaborate now internationally. I've learned a lot from you. I think we're part of a group of pharmacists that do research kind of globally. How do we do more of this? And that's the challenge. I mean, we got to kind of impart this on our students, I think, right?
I think it is. It requires a lot of collaboration, broad thinking. Right now is the best time to try to collaborate. And as you mentioned, like our group of pharmacists that are coming from all over the world, different countries, and trying to come together to improve the pharmacy practice and to collaborate on different things. And one small example of that, for example, in Qatar, we tried to bring the 3 anticoagulation clinics together to build a network of anticoagulation in Qatar. And we have been successful actually to secure a very good grant looking at a registry on the use of direct oral anticoagulants. So again, it's all about collaboration, collaborating nationally, collaborating internationally to try to bring more data, and you'll be able to get more evidence.
Hey, to our listeners, if you've never come to a FIP, and it moves around, I think next year we're in Abu Dhabi, so we'll be close to you, and I'm looking forward to that. But getting to EHP or some of these big international conferences, I mean, if you've never done it, it really opens up your eyes to like all the wonderful things being, conducted all over the world. But for me, it's the networking, be able to sit with you, be able to go grab a drink with, someone from the UK or someone from Africa and just kind of, just shooting ideas back and forth. Like I urge pharmacists, the cost is worth it. You'll get a ton out of it. The talks are awesome. And like you look at FIP, it's a broad range of talks. You literally could go to pretty much anything throughout a day. And it's a long conference, it's like 5 days.
Yes. And I think really coming to these conferences is very important. I learned that when I was a PhD student. At the beginning I said, what is that? All that crowd? What are they here for?
Yeah.
But then I learned really that this is the opportunity to meet people, to learn new things, to get ideas about new research opportunities, education opportunities. This is the place to be.
Yeah, we were going through the airport here in Glasgow when we landed, and one of the customs guys is like, how many pharmacists are there? And I'm like, a lot. There's a ton here. I think this conference, it's over 3,000, sometimes 4,000. Abu Dhabi, I'm looking forward to it. Never been to that part of the world, but I imagine we're going to get a different group of people coming to that. And that's what I find with FIP. Sometimes you get a lot of Europeans, depending where it is. Other times you get South Americans because they move it around, and it's just a wonderful experience. So kind of maybe if you had, one thing you would say to your students or students listening kind of abroad, what's that one message that you'd say, this is coming from you?
Well, I would say that never stop learning. I think the horizon is full of new things and new ideas to learn about. Try to always be active, learn more, get involved more, learn from other people as well.
Sure. Mentors are important. On that note, Hazem, thanks again. I look forward to seeing how much traffic we get on this one. I think we're getting an international audience, but I'll see you tonight.
Thank you, John, for the opportunity.
Awesome.
This podcast was brought to you by IPACT, the International Pharmacist for Anticoagulation Task Force. Visit www.ipact.org for more information.